Welcome everyone to the webinar today. We'll wait just 1 minute to give folks time to join the webinar platform, and then we'll get going. All right, welcome everyone to the webinar. Providers, payers, and employers partner for the next wave of value-based care. First, before we get started, I'd like to introduce myself. I'm Adrienne White, and I'll be standing in for Dr. David Nace, who has had a personal emergency today. And a few housekeeping items. We will be taking questions today throughout the webinar. We want to make this very interactive. So please do drop your questions into the chat box, and we have a team that will be monitoring those and presenting them to us for the presenters. Now let me introduce our speakers for today. Doctors, welcome. First we have Dr. Glenn Steele Jr. Glenn is the Vice Chair at the Health Transformation Alliance and former Geisinger Health System President and CEO. Dr. Steele sits on the Board of Directors for WellCare Health Plans, Ingenious Med, PT Therapeutics, and other boards as well. He is also one of the members of our Innovaccer Strategic Advisory Council. He'll be joined today by Dr. Paul Grundy. Paul is the Chief Transformation Officer here at Innovaccer and the founding president of the Patient Centered Primary Care Collaborative. He is affectionately known by many as the godfather of the patient-centered medical home for his work in the medical home movement. Paul is also a member of the National Academy of Medicine. So thank both of you for joining us today on the webinar. Let's get started. When we hear about employee health and well-being, Paul, why don't you tell us why this is so important to business?
Absolutely, and thank you very much for all of you for participating today. So obviously, one of the keys for an employer is to have a healthy and productive workforce. And the other big concern for the employer is talent. They want the best and the brightest of talent, and one of the key decision makers for people joining a company is how well their health benefit plan works and how effective that is in keeping their family healthy.
Yes, excellent points. Dr. Steele, do you have anything to add to that?
Yeah, the average, it's interesting. A number of years ago, many of the large companies that are self-insured took an approach where they were willing to give a certain amount of money for each employee, and they just assumed the employees could go out and choose their own health plan, their own insurance coverage, and what have you. And they've now changed. It's really 180 degrees. The large companies that are self-insured have now decided that they have a 12 to 13 year relationship on average with their employees, and that working together with their employees, they will be able to leverage and design and support the real value-based health plans that will actually affect health status over those 12 to 13 years. Better health status obviously means not only better recruitment possibilities, as Paul said, but better productivity over that entire duration of interaction.
Yeah, that's a great point. And it's interesting when you look at the cost for that employee. And this is something that I know employers have been looking at for a few years now.
So Adrienne, when I first started as as somebody in our health benefits side of IBM, I guess almost 19 years ago, we were spending on average about $4,800 per employee. That would include the cost of their dependent care. And we became quite concerned at that level of cost and the rise of that cost. So we began putting in place some changes all those years ago, which included no cost primary care. So really focusing on upstream care to prevent, higher downstream cost. And we were able to actually decrease cost for a while. I think that even still to this day, we're a few $1,000s less than some other employers because we put in place, pretty effective wellness programs and first dollar primary care, really trying to establish and move our patients into population health management.
Right. Great points, Dr. Grundy. When we look at the employer-sponsored healthcare program, Glenn, can you tell us what you're hearing out there as you talk to large employers?
Yeah, we've been concentrating right now up to now on the positive benefits of having employers work with employees over a protracted period of time to improve health status. But there's also a negative, I think, forcing function here among the largest companies, that particularly those that are self-insured. They realize that as the public payers move more and more to value-based care, or really screw down on the reimbursement in the old fee-for-service system, that one of the last remaining high-margin products that the providers are banking on is based on the commercial payer, and particularly the self-insured large companies. So even though if you're an integrated health system, even though that self-insured component of your revenue is small, by and large, it remains the largest margin for your bottom line. And guess what? The self-insured employers do not want to be the last engine of margin distribution left in the payer complement.
To that
Yeah.
point, to that point, Adrian, during the time that I was at IBM, we saw a shift in cost, i.e., a shift in what a hospital would charge a large employer versus a public payer like Medicare and Medicaid, from about 17% to almost 27%. So a lot of those folks that show up in the emergency room to get their care and have no coverage or have high deductible coverage now, there's some place that cost has to be shifted to, and to the point that Glenn made, that's to the large employer. So that's a big concern. One of the things that's quite interesting now is that CMS and the public payers for the first time are really shifting their thought about how they're going to pay. We were stuck behind the fee-for-service world that Medicare paid because they were the biggest gorilla, in the forest. And as they shift to value, it's going to be really interesting. And an organization like the one that Dr. Steele leads works in the Healthcare Transformation Alliance, it's going to be really interesting to see how employers also begin to face the shift away from fee-for-service to value.
Yeah, one thing that I'm reading in the research is that the high deductible health plans have kind of plateaued, and that in 2019 we're actually seeing that enrollment decrease with employees opting for more choices. Are you hearing about that out with employers, Dr. Steele?
Yeah, choice is still a big, part of how consumers and particularly employees determine value. It's really interesting when those of us who are in the supply chain talk about value. Quite often, we don't understand what value means for the people who are actually getting our services, and value still means to them still means choice. Now, there's a tension between having complete choice and being able to use providers or PBMs, pharmacy benefit managers, in the case of the pharma supply chain, that that actually give you the best the best product. And the best product is not just the lowest price per unit. It's the appropriate unit of work. So there's a lot of tension between this concept of complete choice and actually having providers that are chosen because they give you a valuable product. And that's something we're still struggling with in terms of narrow networks. I mean, the big jumbos do not like narrow networks for the reason that that you brought up in your question.
Right. Excellent point. So I'm curious how well you feel employers are positioned to really tackle the challenges they're facing, and especially some of those we found in our research.
So this is Dr. Grundy, Paul again. Again, we managed to pull together 47 of the Fortune 100 15 years ago to really drive a concept of the foundation of delivering population health from, i.e., moving primary care away from doing an episode of care towards proactively managing the population with data. We now have close to 50% of family physicians, for example, that are practicing in that style of care, medical home, and now 38 to 40% of payment is no longer in that fee-for-service bucket across much of the United States. So, I mean, I think that shift began to build a platform to really move employers into thinking about a better value proposition. And I know that Dr. Steele and the Healthcare Transformation Alliance has many of those same employers and others that are now trying to think how best to move towards value and shifting. I mean, the story that I like to tell is the one of the Uber driver whose wife was a teacher at a school with a high deductible plan. And when I asked the question, why didn't you have your hypertension treated when she ended up with a stroke at 47, was because it would have cost me $150 out of pocket. And I just didn't have $150, right? So that issue is really driving change.
Yeah, I would say that Uber, actually, Paul, is not a good example compared to lots of the jumbo self-insureds that we have for a lot of reasons. But I get your point. The value proposition really depends an awful lot on how much money you have to pull out of your pocket for a given service, as opposed to the total cost of care, which is much more important to the sponsor or the large companies that are presenting different products to ensure their employees. One of the key things that gets to your earlier point, Adrian, which has to do with narrow networks versus choice. I think compared to when Paul, when he was at IBM, pulled together the 47 companies, we have a huge advantage now that Paul didn't have. And that is, since the public payer, both Medicare as well as Medicaid, particularly since so much of it's moving to Medicaid managed care in the states, is pushing people to do value-based care and to create virtual integrated systems through ACOs and risk share arrangements. What we have are more and more providers that are gearing up to actually share risk, which means that there's a fundamental attack on overutilization or misutilization, and they benefit from it. Paul didn't have that years ago. And what we're trying to do for the self-insureds is to add on to that. So if we go into a very robust fee-for-service market like Dallas-Fort Worth, even there, the organizations that are the dominant provider organizations realize that over 5 to 10 years, that fee-for-service component is going to diminish. And so we actually have a receptive audience. And what that receptive audience means is that more and more of the providers in that market are going to change towards value-based and risk assumption. And that's good for us because that means we don't necessarily have to have a very, very small, narrow network. And again, that's, that moves us in the right direction in terms of what employees want, which is choice.
That is an excellent segue. We're getting some great questions, but our first question was actually, how are you seeing the value-based shift manifest itself from an employer perspective? Are you noticing any positive or negative impacts on the employer health benefits market because of the ACA and the shift to value-based care?
Paul, you want me to take this first?
Yeah, I mean, I think you kind of were leading into that, Dr. Steele.
Yeah. So my latest learning curve, which has been extraordinarily acute, is how difficult it is for us to scale quickly and widely what would be a real value-based benefit amongst our 50 Health Transformation Alliance members. We represent about 7.5 million sponsored lives, about 4 million in the United States, and the other 3.5 million internationally. These are large companies that are geographically diffuse. And so any product that we bring them has got to be scalable. Otherwise, it's not worth the time and effort of their very limited benefits management staff to consider. Beta tests generally don't work when we're talking about these 250,000 FTE employers basically. So that's number one. Number two, the benefit that we bring to them has got to be almost easier to transact than the benefit that they now have. Otherwise, these very small resources that are dedicated to the benefit design and benefit transaction can't handle it. And then the third thing is all of this has to be based on data sharing. Data sharing is the most important predicate to look at variations in cost, variations in utilization, and variations in outcome nationally and market to market. And it's taken us probably 3 years to get the agreements in place that allows HTA essentially as a cooperative to look at the variations and then to start to target our solutions based on the greatest variations.
That's actually a great segue into another question we just got, which is asking, where do you see technology helping to change physician and caregivers who are trying to practice standardized evidence-based medicine and therefore control spending that way?
So this is Dr. Grundy. I mean, thank God we're moving into the age of intelligence, because for the first time, we're really going to have the data that the delivery system and the docs will need. It's going to do for the minds of the physicians what X-ray and imaging has done for their vision. It's going to make it clear what's happening to their entire population, those who are in front of them that day and those who are not. And increasingly with that data, there's going to be accountability for data. Whenever you have data, there's an expectation that somebody will be accountable for it. Increasingly, and Glenn can comment on this, I think the large employers are really going to try to push towards managing the comprehensive population that they care for, and really looking at the data around, the vast differences in data that exist across the country. we're going to move our jobs to places that provide higher value, and we're going to move our patients to places that provide higher value. I think we not only in the near future, but I think we've already started to do that.
No, I agree with what Paul said. I think there's two answers to your question, Adrian. Number one, I think that in order to look at optimal care, you've got to know where you stand if you're a provider versus others in taking care of a disease or a disease entity. And you've also got to know where you stand in relationship to an individual patient in hitting all the things that that have to be solved. Whether you call it gap analysis or mitigating gaps or what have you. So that's number one. And that data, now that we're able to transmit it digitally, it's not a technical issue. It's usually a social issue, a cultural issue, and quite often a contractual issue to have that data flow to the quarterback, whether the quarterback's a specialist or whether the quarterback's a primary care physician. As far as companies are concerned, there's got to be a firewall, obviously, between the data that is so important in the provider-patient or provider-employee relationship. But quite frankly, as it rolls up in an anonymous way, the sponsor of the plan has got to be aware in real time that the provider organization that's part of the panel is performing in a way that is value-based, not, and it's got to be as close to real-time management as possible. Otherwise, you get to the end of the agreement, and then you find out whether you've gotten a value-based product for your employees as a whole or particular cohorts, and that's after the fact, and it's too late.
Right. Yeah, and I think that's one of the exciting parts of employers entering the scene, is that it really becomes a win-win from a cost perspective for the employer. It's of course a win for the payer, and then for the employee, the employer wants the employee to thrive. So it certainly seems like a win-win all across the triangle. We thought this was interesting just as a statement on where employers are looking to control costs, and that they really are looking to technology, virtual care solutions as a way to engage their employees and really get them involved in wellness. And of course, we're going to talk about some of these other aspects, especially around controlling pharmacy costs. We'll talk about those in a moment. But let's get moving. We had a question earlier about behavioral health, and I wanted to bring this slide up because this looks like one of those top concerns. Curious, Glenn, if you're hearing this from your employers.
Oh, absolutely. And again, Paul and I are of one mind on the fact, if you had to do one thing, if you were only allowed to do one thing to transform healthcare delivery in the United States, that one thing would be to assure that every human being, and in this case, we're talking about every employee, had a quarterback to either keep them, as healthy as they possibly could, or to, optimize their caregiving once they've got a chronic disease. And a huge component in that now, which is becoming, I think, appropriately much more front and center, is behavioral, and our ability to combine, particularly with digital, to combine the combination of primary care or quarterback plus an expertise in behavioral is, I think, one of the more positive vistas that that we're betting on in terms of Health Transformation Alliance, and a lot of other organizations are betting on it as well.
So every chronic disease has a behavioral component to it, is my thought in this. And you really need to get underneath that if you're going to change the dynamics of the cost of our chronic disease issues.
Yeah, great point.
Yeah,
So
the
let's,
opioid. I mean, the opioid thing. We're not, we're not trying to avoid talking about that. But I mean, there's obvious. There's if you look at the distribution of the opioid problem, and you look at every step in the supply chain, you'll find maldistribution. You'll find things that just can only be explained by overuse, misuse, you know, uh, uh, incentives that are not based on the best outcome for the human beings we serve, and and that includes a lot of the information that we're putting together in terms of our employees. And I would say that whenever you're trying to target solutions, and there may be political and there may be legal and there may be regulatory issues about those solutions, but the best way to target those solutions is to do a data analysis and look at unusual, unexplainable distribution patterns.
And that pertains not only to that overutilization that really has gotten highlighted with opioid use, right? I mean, including, by the way, some members of one of the families now perhaps going to prison over that. Greed is really the root of that. It's not just with opioids; it's with all of healthcare. I mean, we were looking at some years ago at the rate of stents being placed in our employees at various parts of the United States, and in Wichita, Kansas, for example, you were 4.7 times more likely to have a stent put in your coronaries than if you were in Cleveland, Ohio. And so we began looking at actually, not allowing stents to occur in some places where they had high overutilization. So, when you do fee for service, you're going to get too much service,
okay.
and that's the case. And that's the case of how we got into trouble with opioids.
Well, I
So
think again, Paul, let me just, this is all supposed to be hunky dory and we're supposed to agree with each other, but let me add something else. I, I mean, I do believe that at least when I was brought up as a clinician caring for patients, there was a lack of there may have been a lack of appropriate response to pain. And during my almost 40-year career, the first 25 years of which was caring for patients, there was a revolution in the fact that we were reconditioned appropriately, I believe, to start paying much better attention to pain, whether it was acute pain or chronic pain, and that was a good thing. But what came to fruition was this belief, to some extent, promoted by organizations that were greedy. But there was this unfortunate misconception that opioids were appropriate for chronic pain mitigation, and we're just now finding out, that there are much better ways to deal with it. So I mean, it wasn't simply greed. It was a lack of understanding and a movement from that lack of understanding that we had to better deal with the question of acute and chronic pain. It just was done in the wrong way initially.
I would agree with you on that, absolutely.
okay, so let's move to our first poll. We'd like to hear from the audience, and we'll be asking you about how you utilize your own employer-sponsored benefits. So if we can run the poll, and we'll see the questions. Please answer all that apply to you. If you're using your benefits only for emergencies because you have a high deductible plan, or perhaps just for your annual physical and any rare emergencies that happen, or if you're using that benefit every month to refill prescriptions, or if you're actually using it on a regular basis, at least once a quarter or so, to manage chronic disease. So we'll give folks a moment to answer the poll. And just a second here. We'll give it about 20 more seconds, so please answer the polling. And I think we're going to close the polling now. We're at about 60% participants. And so let's see how we answered. The results of the poll, please. So here, it looks like the majority of folks are really just using it for their annual physical, for emergency visits, and then for medications. Is that about what you would have thought, Dr. Steele?
Yeah, I think our demography is generally a working, healthy demography. So this doesn't surprise me at all. Um, and I guess again, when we're talking about the jumbos, we go anywhere from 5,000 sponsored lives up to almost 300,000. So my suspicion is, as we get some of the older demography in there, it would look a little bit different in terms of chronic disease management. But it doesn't surprise me. Does it surprise you, Paul?
Not at all. It would surprise me if this was a Veterans Administration population, but certainly not for an employee population.
Yeah, exactly.
Okay, good. So Dr. Grundy, how well positioned do you think the employers are to solve the kinds of problems we're seeing around lack of access, differentiation between services with disparate costs, and then pricing models that are not aligned? I know that you speak a lot about these issues.
So I think we're probably about no further than a quarter of the way there. I think we've made some movement around, really moving towards more robust primary care as a foundation of population health. And the large employers have helped drive that. Fortunately, government jumped in and helped as well. But I think we're making progress, and I'm a bit optimistic that we're going to move away from, a body in a bed being a profit center to being a cost center, and that'll change the dynamics a bit around that. I think as large employers, working both collaboratively with government to help them change their policy, i.e., for example, high deductible healthcare plans, adding to that first dollar primary care would make a huge difference in the marketplace. And I'm optimistic that folks like Glenn and their work with Healthcare Transformation Alliance and what Haven is trying to do with 3 of the large companies will perhaps make a difference. Glenn, your thoughts on that?
Oh yeah, no, I agree. I'm despite my age, I'm still pretty optimistic, which is why I'm still in the game. But but I think you look at Pacific Business Group on health, you look at Haven, you look at individual companies that go all the way back to Pitney Bowes and Safeway before they got bought by Albertsons. You look at Boeing, you look at GE, you look at IBM. Of the 3 Haven companies, 2 of them are parts of Health Transformation Alliance. So, they're I mean, it isn't easy to do something which is scalable nationally or even internationally. It isn't easy to do something that is transaction friendly compared to what most of the benefits managers are buying now. But there's an awful lot of angst out there, and there's an awful lot of movement, and I think that's good. Again, I agree completely with Paul that if you had to do one single thing, you would assure that the employees had an incentive to have a quarterback even before they had a chronic disease. And whether that quarterback was a nurse practitioner, or whether the quarterback was a pharmacist, or whether the quarterback was a primary care physician or an internist, or in some cases, even an oncologist or an endocrinologist, depends on the individual patient. But the quarterback is the thing that we really need to design our benefits and our incentives around.
Yeah. So, and the good news is it looks like employers are very much aligned and that they do plan on investing in healthcare benefits for the workforce. So I know that we've seen this kind of go up and down since this whole idea started, but it looks like the trend now is that they're going to continue to offer these benefits.
Well,
Um,
not only that, Adrian, but when you hear some of the, I don't know how many, what is it, 22 or 23 candidates on the Democrat side, some of whom talk about single payer or Medicare for all, whatever that is. I mean, with that last slide, showing an increasing number of large employers, particularly the self-insureds, but overall the employers becoming much more interested in partnering with their employees to get value. I don't think that's going to be given up very quickly, by the voting population.
yeah. And we can see here some really good reasons why employers find it so important to offer good healthcare benefits. So
One of the concerns that I had was focused on one of your earlier slides where you saw the two top focus areas for large employers, and one was remote management, and the second was focusing on high cost utilization. Remote management without that trusted healer, without that quarterback, doesn't work very well. We have learned, certainly not only in the United States, but in the work that I've done in Denmark. And secondly, when you focused only on your high cost, and we did that at IBM, when you focus on your high cost, the high cost folks next year are not going to be the same ones. You really have to look lower into the food chain of chronic disease before you have any success. You really need to address behavioral issues. You really need to address, the routine screening, the primary care earlier if you're going to impact cost. But if you only focus on your high cost patients, you're really going to be in trouble.
well, and that's a great point, Paul. And I thought this was an interesting quote from Brian Marcotte, the president of National Business Group on Health. And we know that the National Business Group, as well as the Pacific Business Group, is just doing some excellent work on giving us insights into the employer market, but that employers really are looking for disruption in how they engage and how they manage their benefits. And we're seeing that across the market. It's an exciting time. We've got, of course, lots of improvements in how we manage the data and also at how we can deliver critical insights at the point of care. We're seeing that at Innovaccer and also in other startups in the Valley as well. And speaking of that, I'd like to share this video now. It's a video that Dr. Steele did for Innovaccer that talks about our point of care solution. So let's just pause and watch this video.
I think the bottom line of what's missing today for technology enabling behavior change in how we care for patients is the fact that products have been developed that don't necessarily meet the needs or create solutions for the caregiving problems that our physicians face.
So the beauty of the EndNote software is literally when you click into your patient's chart on your EHR, out slides a screen that tells you more about your patient that you don't have to go look for. Instead of having to hunt and peck to find out when was the last colonoscopy or their pneumonia vaccine, that you're able to see these are the care gaps that are missing.
Innovaccer is able to aggregate the claims data and process it immediately and make it available to the physician with the patient and the patient's family in front of the physician. And not only have it available, but have it put onto the same screen that the physician is looking at.
It greatly simplifies workflow. It saves a lot of time. But what do you do with that time? Well, now you get to talk to your patient. EHRs for so many years took you away from the patient. You have providers typing, clicking, using Dragon, everything other than interacting with the patient. And that's what the patients want, and that's what we should be doing.
Yeah, well, Innovaccer is actually creating a series of partnerships that put the engineers who are wowie-zowie engineers with the physicians who know what the problems are that have to be solved.
So we all know what it looks like for rolling out software in a challenging environment, very difficult. We found that Innovaccer's team We're so incredibly responsive to customizing the software to how my physicians wanted it.
What we start with is really a great group of engineers. We have a pliable product which is agnostic to transactional EHR, and we are committed to partnering with physicians so that we know what the solution is that we're focusing on in the first place.
My doctors and the care managers and the wellness nurses all report they're much happier with the visit because they're spending more time doing what they thought they went into school to do. Take care of patients, talk to the patients, and have an impact. They're spending less time looking through the EHR. They're spending less time pecking away on the computer. This improves physician satisfaction. And when you get happier doctors, more engaged physicians in taking care of patients, you just get better outcomes.
So, Dr. Steele, before we move to our next poll, I'm curious if you can tell us your thoughts on how employers might find a tool like EndNote helpful, or in the employer, physician, employee triangle, how would a workflow tool like EndNote be important?
Yeah, well, I mean, the employer is interested in the outcome for the employee, basically. And the employers that we work with in HTA do not want to get in any way in between the employee and the employee's physician. But anything that improves the interaction between the employee and the employee's physician, particularly if it's really going to improve the choice of care, the optimization of utilization, the correction of issues in real time, filling of gaps, and anything that does that is going to be of value because there's going to be a better outcome for the individual employee. So I think that's the way I would posit the benefits of the Innovaccer functionality.
That makes sense. So let's move to our.
And Adrian, I was just at a large hospital system where they were the largest employer in the community. They were able to use Innovaccer, really getting at managing the population more effectively, saving time for the provider. And they drove down cost by about 11%. And they were able to offer that to the other employers, and particularly the smaller ones in that region. So it was the primary care docs that were delivering care to the hospital's employer that were all of a sudden delivering care, to the local motorboat manufacturer, et cetera. And I think that model I've seen begin to work in a number of communities.
So just to pursue this a little bit more, I mean, if it's a wonderful thing that we now have EHRs, and we wouldn't have had them if the government hadn't required us to have them. The issue with the EHRs, though, in terms of the doctor function, is immense. And Innovaccer is one of the solutions to really creating the functionality. And it's a functionality that will only be used by physicians or the nurse practitioners if they don't have to toggle between screens. So what Innovaccer does is it allows a lot of information to be put on the screen that is the transactional EHR screen, so that the doc or the nurse, whoever's the quarterback, doesn't have to toggle. And that's a really important deal. Now, to get to the core here, we all know that probably 30 to 35% of the cost in healthcare right now does not bring benefit to the people we serve. And if we're able to get some significant percentage of that out by doing the right thing, not doing too much, not doing the wrong thing, not doing too little, and we can actually take that down to the individual relationship between a patient and a physician, that's where the value gets emancipated. And we can talk later, not just conceptually, but with real detail about some of the early results with, some of what we've done with HTA, and we're looking, at between 15 and 20% decrease in cost, and not decrease in outcome, but benefits in outcome.
Yes, excellent points. I know one large employer that we work with, they have certain metrics that they're concerned with. And so we are able to put those metrics in front of the primary care physician at the time that the patient is during the visit. And so they find that very helpful in fulfilling the obligations of the employer contract. So I think these are all excellent, points to make. So let's move to the poll 2. And this will be the second poll for our attendees. If you could please answer the poll and choose the one best answer here. As a large employer, what technology would be most important to you? Would it be tools to understand utilization and cost of care? Or would it be tools to communicate the patient's case information to the doctors, or perhaps those special metrics that you're most interested in as part of the contract? Would it be population health tools where you can check for variations in cost and quality across your employer POP? Or tools that would show the performance of your contracted providers? So let's do the poll. We're going to open the poll now to attendees, and we'll wait a second. We'll wait a couple more seconds for folks to vote. And let's close the poll and look at the results. And the results are in, and it looks like understanding utilization and cost of care is at the top of mind for our employer attendees. And then second would be population health tools to check for variations in cost and quality. So very interesting. All of this is really interesting to me because so often I am not working on the employer side, but it seems like they have many of the same concerns as our provider customers. So that's interesting. So let's move ahead now and talk about what we're seeing as employers are redefining that relationship with physicians on behalf of the patients. We can see there's many companies now that are coming up. These are the innovative companies that we've talked about. Dr. Steele, I know you and I have talked about this. Do you have any comments on the ecosystem?
Well, it's incredibly vibrant right now. I mean, a huge number of companies have been created and are continuing to be created to sell directly to the self-insured jumbos. No question about that. I'd say the one common theme for most of these companies is either to keep people out of the hospital. I mean, the single best way of emancipating value is decreasing acute hospitalization for a given population of patients. And a lot of these companies are trying to do that pre-acute. The second biggest area of value emancipation is if you have a real indication for hospitalization and you need to have an intervention, which is a hospital intervention. The second value emancipation target is how and where you do your rehabilitation after the acute episode. So those are the two areas that I find to be the most vibrant areas and probably the most rational areas for value emancipation, that's in the universe of the supply chain right now.
Thank you. And of course, Dr. Grundy, what do you think is the secret sauce for really driving this healthcare revolution?
So to the point that Glenn just made, and to the point of the of the changes that are occurring, I think the combination of moving the primary care physician to a role of a system integrator with a team of folks around them that really understands how to follow up and follow through. So a lot of the telehealth solutions, a lot of the remote solutions work really, really well if they're connected in a team-based way to a trusting relationship with a healer and their team. And I think that was key in the Danish experience of going from 137 or so hospitals down to 21 over the last 2 decades, and it's going to be key to us.
Yep, excellent.
I would
So,
guess, hey, Paul, I would guess that the optimal vertical on that PowerPoint 19 is probably about 6 inches.
Okay, thank you.
okay, so Dr. Steele, we want to hear about the Health Transformation Alliance. I know that you guys have done some super exciting things. And here's an overview slide, but the slide I really want you to talk about is the outcomes that you've seen in your pillars.
Yeah, well, there's 4 pillars. The first pillar, which is a predicate for everything else, is sharing data and doing analytics on data that's already available through the third-party administrators for the self-insureds or through the pharmacy benefit managers. And those data are all agreed. They're anonymized, obviously, but they're agreed to be compiled. IBM, which is one of the founders of HTA, Health Transformation Alliance, has created a sandbox to do analytics on those data. And we're basically looking at variations. We're looking at variations of cost. We're looking at variations of utilization and variations in surrogates of outcome that are both national as well as market by market. And as you might imagine, those variations are huge. And that's allowed us to focus on a number of things that are high frequency, high variability, like dealing with low back pain, or like hip replacement or knee replacement, or like taking care of chronic diabetes. Those are all very, very prevalent issues for the demography that's represented by the 7 to 7.5 million sponsored lives in our group. So everybody's got to participate in the data accumulation and the analysis. That's number one. Number two, the pharmacy solutions are based on the usual kind of quid pro quo. We'll put as much volume as possible on our selected PBMs, and they give us a price per unit discount. But more than that, we're looking at transparency. We're looking at utilization transparency as well as cost transparency, and we're basically thinking about redesigning, in particular, our specialty drug supply chain. But those pharmaceutical solutions, out of our 50 HTA members, have about 41 members. It's either 40 or 42. It's around 41 members that participate. And the value that has been emancipated over the last 2 to 3 years is over $500 million. Over $500 million of value that goes back to our HTA members. Because HTA is a cooperative, we don't add our own margin to the supply chain. The medical solutions, we've already seen in a series of beta tests, 15 to 20% deltas in terms of cost versus the side-by-side competitors that are out there. Our big challenge for the medical solutions is to scale it up. We're hoping that in 2020, we're able to offer this to probably about 500,000 or 600,000 HTA sponsored lives. And that's when the value will really come in. And then the consumer engagement, we're very, very aware that we have to have the employees really functioning as symmetrical partners to the providers and probably even to the sponsors, i.e. the companies, in order for us to understand how this stuff becomes attractive to the employees. Because again, our concept of value, for those of us who are in the healthcare universe, is very different than the concept of value for those who receive our care quite often.
Excellent. That was just superb, Dr. Steele. It's so exciting to hear about the success that the Alliance is finding in the market. And when you think about it, it really is going to take alliances like these to accelerate this transformation. If you look, a couple examples our research team found is that, you know, Starbucks actually spends more money on healthcare than they do on coffee beans. And General Motors is spending so much that they're more of a wellness and benefits company than an automotive company. So this is such an important topic to employers, and of course we know it's important to employees. So in the interest of time, we'll skip over that final polling question. And we've talked about some examples already of Haven and some other companies, some large employers that are really doing innovative, disruptive things to drive engagement with their employees. And I'll just ask if you guys have any other examples you think are important to mention.
Many other examples. I mean, we're, you know, two of the three Amazon associated companies in Haven are part of HTA. We're very excited about whatever it is they decide they're going to do. We think we could easily be a distribution channel for them. And Amazon has in particular some significant intellectual property that we think could help disintermediate, if not make more efficient, the supply, some aspects of the supply chain. Walmart is doing its own centers of excellence experiment. We were involved in that when I was at Geisinger. Blue Cross Blue Shield is now has its investment arm of Illinois and Texas has combined with a company to create a digital access primary care network for a lot of its clients. Pacific Business Group on Health has been working for 29 years and has its own group of centers of excellence. Boeing has been at it for a long period of time. Safeway did some really cool stuff, which brought value in terms of reference pricing of pharmaceuticals and some diagnostic and therapeutic procedures. There's a huge amount of real kind of energy and some momentum out there in the world of the employer-based health health benefits area.
To add to that, what I also see happening, and I have seen it now for a few years, is that when employers identify high-performing healthcare at triple aim, at value, they move jobs there, and was one of the key decision makers for Boeing to move its jobs to South Carolina away from Seattle at one stage was because of Palmetto Primary Care. It was because it was a really, really good high-performing medical home with robust primary care and really tight management for the employees. So I think in addition to looking at solutions, I think that when solutions are provided by the marketplace, you know, those jobs are going to move there.
I absolutely agree with you, Paul. Absolutely agree.
Yes, those are excellent points. And of course, this is so important because our health affects us at work and our work affects our health. So this combination of stakeholders, I think, really holds in their hands the key to driving and accelerating our transformation to value in the United States. With that, I would like to thank everyone who asked questions earlier throughout the presentation. We are coming to the end of our time, so we're going to go ahead and bring it to a close. I would like to let everyone know that if you do have questions, you can certainly email them, send the responses over email when you get your link to the presentation, and we'll be glad to share those with Drs. Steele and Grundy. And also I wanted to let you know that when you get the presentation, you can link to some research that we've done on bringing artificial intelligence to healthcare and improving risk models. We have many different risk models that we've developed, including a social vulnerability risk model, and we've done some exciting research around how we make those more accurate and more comprehensive. And with that, I would like to thank our presenters for this exciting discussion and thank all of the attendees today. We look forward to joining you next month for our June webinar.
Thanks, Adrian. Thanks, Paul.
Thanks, Glenn, and thanks, Adrian, and thanks, audience.